Good day, my dear postgraduate students, and also my dear younger faculty. It is nice to make an attempt. The grossing techniques in the last class drew an overwhelming response. Let us see what happens today. This is not an uncommon topic, and most of you are already familiar with it. Some of you are very fluent, and a few are controversial. Let us see what the discussion of the day has in store for us. In this class, we shall be dealing with the anatomy, embryogenesis, types of surgery, grossing, description of a thyroid malignancy, where to take the bits from, and any of the tips for grossing, fixation, etc. Also, there shall be a table regarding the gross appearance of the lesions. References shall follow. Good order is the foundation of all things. Edmund Burke. Now, thanks to WebPath, this is the normal anatomy. So, you find that it is quite simple. The organ is butterfly shaped with open wings, bridged by means of the isthmus. And there are certain common terms such as total and hemithyroidectomies. The orientation, however, shall not be problematic because the isthmus is lower down. 1. Again, the organ has got a convexity on the anterior aspect and a concavity posteriorly. So it will not be difficult at all. You cannot turn it the other way around. Now this is again a line diagram of the thyroid. We have already seen the hyoid bone and then the cartilages, etc. So you have got the right and the left lobe connected by means of an isthmus, from which sometimes there can be the appearance of a pyramidal lobe. So this is what you people should be having in mind. It is posterior to the sternohyoid and the sternothyroid muscles. It wraps the cricoid cartilage and the tracheal rings. It is inferior to the thyroid cartilage and is located between C5 and T1. Thyroid, esophagus, trachea, pharynx are all in a visceral compartment called the pretracheal fascia. So this is important both for surgery as well as the complications it shall be bearing. Ultimobranchial body is something that we will have to have in mind. Even before I go to the next picture, I always touch upon the lymphatic drainage. So there is something called the prelaryngeal node and two groups. Just remember two. The upper deep cervical nodes and the lower deep cervical nodes. In front of the trachea, of course, there is a pretracheal node, and on either side you have got the paratracheal nodes. The mode of spread we people will have to remember because it is not very common as the breast, and hence this will be useful. Coming to our friend, the ultimobranchial body, you find that this is the development of the thyroid. So there are the various structures which are developed from the pharyngeal pouches. One is the thyroid gland, two is the parathyroid, the blue in color. Next is the ultimobranchial body. So these are all the various outpouchings that you people can see. And ultimately, this is a developed thyroid that you people see. So this is the thyroid gland along with the parathyroid gland over here. And these are the C cells of the medullary cells. So I would like you people to kindly have this mind. The ultimobranchial body is responsible for the C cells. This is again the development of the thyroid because the thyroglossal cyst is not uncommon. You would have already seen, diagnosed it, arising from the foramen cecum, which occurs at the anterior two-thirds and the posterior one-third junction. And it goes down up to the level of the isthmus. And after the embryology is over, it disappears. But sometimes it can be persistent to form a thyroglossal duct, from which a cyst also can occur. So there is a thyroglossal cyst over here, and there is a persistent thyroglossal duct. The histology is what we see. There will be a pseudostratified ciliated epithelium and then a muscular one. You may see also the thyroid follicles along. Cisterns operation is done for the surgical treatment of it. Coming back to the anatomy, it is composed of symmetrical lobes, the thyroid, connected by isthmus. There can be a pyramidal extension called the tubercle of Zuckerkand. The weight is approximately, say, around 20 grams. 15 to 25 is the range that has been given. Develops in the third gestational week. The morphology can be slightly variable. Mild asymmetry is permissible. Situation is surgically important and the function is also significant. All of us know about it. Sometimes when there is a high dietary iodine, the weight can be reduced, and before the iodinization was initiated, it was as much as 50 grams in countries such as Switzerland. Ectopic is one which develops in the pathway of embryology or embryogenesis. That is ectopic. Whereas if it is outside this, it is called as aberrant. Now, what are the indications for a thyroid surgery? Let us have this in mind. Why at all should we have a specimen? It can be straight away because of a tumor, or there are nodules which have been placed under suspicion by FNAC. We are not sure about it. Hyperthyroidism, that is refractory to treatment, and pressure effects. Commonly, the patient complains with difficulty in swallowing or even breathing. Cosmetic reasons, when it is too large, and sometimes as a prophylactic treatment to men 2A, men syndrome. So these 6 points I would like you people to have in mind. Thanks to Tata Memorial Center for this list. And this incidentally, obviously, it far exceeds the 50 grams that I have mentioned, but the lobulation or boscillation can be well made out. The pressure effects are self-explanatory. And what are the surgical procedures? The procedures can be lobectomy or hemithyroidectomy. One lobe is being removed. Hemithyroidectomy means there is the lobe along with the isthmus that is being removed. Subtotal thyroidectomy, wherein a part of the thyroid parenchyma is retained for functional purpose as well as to retain the parathyroid glands. Total thyroidectomy, an entire gland is being removed. Completion, when the surgeon revisits it, when there is going to be a defect or there are multiple nodules or specks that have been identified by radiology. Each type is accompanied by a central compartment, and there can be also a modified radical neck dissection. And I had shown you the notes that can be included in the surgery. You people should be familiar with the terms of the surgical procedure, what should be the fixation, and there should be a concurrence with the preliminary report of fine needle aspiration. So this will be the sixer for us. The types of thyroid surgery and their indications again are given in a tabular form. I would like you people to kindly go through it. Hemithyroidectomy or lobectomy. For example, Bethesda score 4. And also if the nodule is going to be small, probably we are convinced that the lobectomy alone will be sufficient. Sometimes it is done for a further histological diagnosis. Isthmectomy again when a small nodule is confined to the isthmus alone. Near total removal of most of the gland in a case of a large nodule and also to preserve the parathyroid as I had mentioned. Total thyroidectomy in large tumors more than 4 centimeters, poorly differentiated carcinomas or anaplastic carcinoma, and also as an adjuvant mode of treatment after the radiotherapy. Completion will be when the tumor is larger, multifocal, residual disease, we will have to revisit it and remove whatever is possible. Neck dissection, clinically and radiologically, they are involved. And frozen section, whenever there is an inconclusive FNAC, frozen can precede the surgery. Step-by-step procedure. So, the weight. Always, what we students forget to do is, even in the examination, we do the measurement, but we do not weigh the organ. This is mandatory. And a three-dimensional measurement. The length, breadth, as well as the thickness of it. And subheadings are subheadings. This is almost similar to a surgical examination of a lump. And these are the steps that we usually follow. Weighing. In fact, we circumvented in the examination. I advise you students to kindly do the weighing of any organ before the measurement. Three-dimensional measurement and the usual description of the size, shape, color, consistency, external surface, cut surface, etc. When a tumor is suspected, there has to be an inking of the surface that is close to the tumor. Regarding the sectioning, there are two things. I'll be showing you the pictures. Have this in mind. It can either be transverse or it can be longitudinal. Longitudinal is along the longest axis. And it should preferably include both the lobes and the isthmus so that you have got one half that can be stored and the other half can be grossed comfortably. The preserved half can be revisited if needed or mounted. Some books say that it has to be at a frequency of every 5 millimeters, whereas others are more generous. They say that as and where you judge it is correct, depending on the various things. If there is going to be a variation in the color, consistency, etc., that has to be sampled. Distance from the capsule matters. Remember, there are two capsules. One is the capsule of the thyroid, two, a capsule of the nodule. All these areas will have to be sampled again. Areas of hemorrhage, calcification, so on. And if there is any attached tissue, please do it. Parathyroid and lymph nodes will have to be included if present. Always, diagrams are mandatory and preferably it is better to have gross photos because the specimen cannot be brought back to its original shape. And thorough sampling is also required. Fixation is for a period of 2 days for large ones. 10% buffered formalin. This is for easier cutting and preservation. And anything can be correlated with the radiological picture. There are always some details which we fail to get. And we start running after the clinician or chasing our PGs to get them. But these are mandatory. So I would like you people to kindly go through the entire list. For example, thyroid function, antibody profile. It will help us very much in giving a diagnosis of a Hashimoto's diagnosis, thyroiditis. Whether there is a family history and so on. So this entire list I would like you people to have at your fingertips. What are the rules for any description? 1. Identify and mark the upper and the lower parts. We are marking it because once you cut the specimen, you cannot reorient it. As I told you, the lateral, anterior, and the posterior concave surfaces can be identified. Sampling should be done with the surrounding tissue. Whether it is the kidney or the thyroid, always have the surrounding tissue intact so that you will know the degree of infiltration. The pointed apex. And sometimes the isthmus can be identified very easily by the area of cauterization and any other sutures or clips left behind by the surgeon. A schematic diagram is mandatory, and digital photograph is also required for an invasion. I'll show you one of the pictures again. Microcarcinoma, you'll have to do it at a lesser thickness of 2 to 3 millimeters. Look at this particular picture. There is an inking that has been done. Probably there is a lesion over here, and this is the one with the isthmus. There will be here also an inking will have to be done so that to say that this is from the isthmus as such. I told you that there are two methods of grossing. So one will be multiple parallel vertical sections, as a result of which you get a generous view of the cross sections of the thyroid, but the specimen will be lost. So this is a serial sectioning, particularly when an invasion is being considered. Now, in a case of, say, autoimmune thyroiditis such as Hashimoto's or Graves' disease, maybe a slice, and if there is going to be a variation, that will be sufficient. In cases of multinodular goiter, the normal parenchyma along with areas of hemorrhage or calcification. Suspicious area which are solid or sclerotic. Papillary carcinoma, if it is going to be very small, the entire lesion can be given a cross section of. And when it is more than 2 centimeters, an interface between the tumor and the normal thyroid will have to be. Uninvolved thyroid is a routine, so that we have it for record purposes as well as to diagnose what is in the back. Look at this. So describing a specimen will be mandatory. You are supposed to mention what type of a thyroidectomy it is and what are the lobes that you people are seeing. What is the measurement of each and whether the surrounding capsule, is it transparent? Are you able to see the underlying parenchyma? Is it smooth or is there a boscillation? And what are you finding at the isthmus? A bit of the pyramid is also seen over here. Similarly, the posterior surface. Any additions, etc., can be specifically mentioned. Measurements are mandatory, weighing is needed. This is one way. And another way will be, this is the interface between a nodule and the normal parenchyma. So it can be cut so that you get multiple sections. So there are two modes of cutting. You people will be having this in mind. You can go through this leisure. A higher magnification, I would like you people to kindly explain this. Now, what are the gross appearances of the various thyroid lesions? MNG, you find that there is asymmetric enlargement, nodularity. There can be calcification and cysts. Graves' disease, beefy red, symmetrical because of autoimmunity, no nodularity. Hashimoto's, again symmetrical, it will be tannial, diffuse. Sometimes it can be multilobular because of fibrosis. There are three variants of it. I will be showing you a picture of it. Papillary carcinoma, nuclear papillary excrescences, cystic with solid areas. There can be projections. Otherwise, it can be friable and an invasion into the thyroid capsule can be noted. Follicular neoplasm, adenoma 2 to 4 centimeters larger. Carcinoma, you find that there is a thicker capsule, but there is an invasion that can be made of. Infiltrating border. Medullary carcinoma, located in the middle and the upper third. Tan or mahogany brown is the color of Hertel. And any anaplastic carcinoma, it can be firm to hard with adhesions, necrosis, and areas of hemorrhage. Web pathology, great picture. So obviously in the thyroid, there is asymmetry. There is nodularity. I am able to see some areas of hemorrhage, and this also is over here. So this can very easily give us a diagnosis. And elsewhere, I can feel the consistency of a soft thyroid. And when I cut it, there will be a honeycomb appearance. So these things you people will have to mention. The cyst, whether it is cold or hot, also can be noted down as from the thyroid scan. The normal picture is given here for comparison. Differential diagnosis will be a solitary nodule. We shall be seeing. So you'll have to do all these things. Now observe the color, consistency, nodularity, symmetry, cut surface, and make a preliminary diagnosis. Thanks to Pathology Outlines, and author is Henry Fishko. The beefy red, classical color because of increased vascularity. Any of the endocrine lesions will be having vascularity because they are endocrine and there is no duct as such. They directly empty all their secretions into the vascular. When the Y is clear, the how becomes easy. Courtesy shutters. And look at the contrast over here. Here again, there is a symmetry. It is solid and not much of honeycombing is made of. No areas of hemorrhage or necrosis. Hashimoto's a good reference over here. Boscillation may be present in a case of a fibrosing variant of Hashimoto's. Look at this one. What is your diagnosis? I'll be tempted to call it a medullary carcinoma if there were any parenchymal cells, mistaking it for amyloid. But here, there are just bundles of collagen and lymphocytes are there. Maybe if I'm lucky, I'll be able to see some plasma cells. Good. So this is a case of fibrosing variant of Hashimoto's thyroiditis. One is a classical variant, two is lymphocyte predominant, which can be mistaken for a lymphoma, and three is a fibrosing variant. Follicular neoplasm. Here the entire capsule with the lesion and the surrounding thyroid should be given. Inking of the outer surface of the thyroid is required when the nodule is close to the thyroid capsule itself. Central portion of the tumor is needed, and also, as I told you, the uninvolved areas. Medullary carcinoma almost the same. And if it is going to be a suspected case of a Men's syndrome, the entire thyroid will have to be sampled for various reasons. We may miss something. Look at this beautiful picture over here. References, surgical pathology, dissection. Pyramidal lobe, everything is over here. And then there is a cut surface. And they are able to find the margin over here. That is why it is being inked. And a cut surface over here will be giving us a sufficient knowledge of it. Multiple sections are being given because there is a nodularity that they have made out. And that again is being divided into 4 pieces, quadrisected. So that there is always a capsule and then there is a lesion, there is an interface. That could be studied leisurely in multiple sections. The way it is being cut at a higher magnification. Artifacts will have to be cut. This is important because the thyroid is a very delicate organ. So when I am in two minds with a seesawing cut, there will be the knife marks and the surface that you get on the tissue will not be uniform. Therefore, it has to be a single deliberate cut with a lancet blade probably. So this is how it is being cut and then it is oriented and mounted. Now, there are some verbs which we can remember and the nouns. Orient, the specimen. Ink, the outer surface. Shave, the isthmus. Submit, bits. Identify, lymph nodes and parathyroid. Show, the interface. Sample, the capsule. Divide into quadrants. I hope this is easy for you people. You can go back to your grammar school. This has been designed by me. Papillary carcinoma occurs courtesy is the endocrine part of web pathology again. Cavity with there is a fine, delicate papillary excrescences. We will not miss it. There is an accessory lesion over here. So we will have to concentrate on the morphology, the invasion, whether it is solitary or multicentric, lymph nodes, lateral aberrant. Lateral aberrant thyroid is a question for you people. You find that it will almost mimic a lymph node, but it will turn out to be a papillary carcinoma. Cystic processes and areas of invasion. Picture will be shown. Measurement is needed at every stage. Huckel primary, what is this one? We all think it is normal. We have also given a normal FNAC report, and then the specimen comes. We study it. Even at a grossing, it is not diagnosed. But when we study it thoroughly, we find that there are some cystic areas which is showing cell with a ground glass appearance, maybe a grooving. And if you are lucky enough, there might be a some body. But all this has been too very microscopic. We call it an Huckel primary. Sometimes there can be a nodal metastasis also in this. Look at this one. There is a lymph node with a metastasis. And the same picture we can see right in the middle of a thyroid also. In which case, the entire specimen will have to be thoroughly studied once again. They have to be numbered, grouped, diagrammed, etc. This is what I had been mentioning. So this is a tumor. I do not know the lesion per se. It is a histological diagnosis. But I am able to see some extensions. And this yellow arrow points out to it. We'll have to see whether it has invaded the capsule or not. The moment it is there, a thorough sampling of the lymph node is also mandatory. So this is an extension of the papillary carcinoma. Now, what you people are seeing in this is another tumor. So I am finding a pasty material over here, and almost the entire thyroid is being replaced by it. So it is lobulated and firm in consistency, courtesy research case. And this also. Here it is not very difficult to make out. There is a fleshy kind of an appearance, an admixture of the gray-white hemorrhagic and the reddish areas. Lobulation, solid, and it can be firm also. That will be the appearance of a medullary carcinoma. This is our friend the anaplastic carcinoma, wherein the tumor is huge, and a radial thyroiditis can be sometimes mistaken for this, and there also you find total thyroidectomy is being done. Courtesy Mark Wick. So, obviously, in such cases, a thorough sampling will be needed, particularly at the areas of hemorrhage, necrosis, gray-white area, cystic degeneration, and the borders. Sometimes we do reach a paradox. Look at this one. There is a pasty, amyloid-like material, but then it can happen in a case of a multinodular goiter also. There is a cystic degeneration. There is no medullary carcinoma in this. And this is far away from the thyroid, thought to be a lymph node. There can be an ectopic thyroid or there can be a papillary carcinoma also. So these terms we people should be familiar with. I want you to differentiate between these two. To me, both look almost similar. In this one, I'm able to see a parenchyma. There is some amount of colloid, but at the lower pole, I'm able to see some, or rather the other way around. I'm able to see some grayish bone structure. It turns out to be a neuroblastoma. It is a post-histology wisdom. Otherwise, it can be mistaken even for a dominant nodule, as you are seeing in a case of a multinodular goiter. So it is this kind of a thing. A nodular goiter, you should know what kind of histology it has. I would like you people to kindly visit Ackerman for the varying stages of the genesis of the thyroid tissue. For the surgical pathologist, the major task will be to identify an infrequent neoplasm amidst the harmless thyroid tissue. So there has to be a coordination of the cytopathologist, endocrinologist, and the surgeon. So these things are all mandatory. Inspection, sampling, diagnosis, which will be followed by the treatment. So these are the important things that we have already mentioned. Imprint can be taken, particularly in a case of a frozen section, so that you can hasten the diagnosis or rest your curiosity. For the final sections, these will be needed. With the capsule with adjacent thyroid, isthmus, the other lobe, parathyroid if present. The mode of cutting. This is what I had been mentioned. If it is going to be as close as this to the thyroid capsule itself, then probably an inking will become mandatory so that you will be able to decide how far it is from the actual thyroid follicle. Look at this one. It is almost similar to what is being shown. It is a nodule that has never been explained. Now, how do you distinguish between a solitary nodule and a nodule in a case of a multinodular goiter which is dominant? So there are certain things which people can read up. There will be a uniformity within the nodule, and then there will be a dissimilarity within and without the nodule. Outside, there will be the compression of the normal thyroid tissue, and it is totally circumscribed by means of a capsule. These things you people should be having at your fingertip. Sampling in this case will have to be done all along because we'll have to rule out an invasion. See how beautifully they have done it. In this case, literally the entire specimen has been sacrificed, multiple cross sections, and measurements have been made at each axis. Thanks to Henry Richard. Pathology outlines. And ultimately, they have been successful to find it somewhat invading the capsule, and that is being made here. Either a capsular invasion or a vascular invasion outside are mandatory for a diagnosis of malignancy. Sections will be, as I mentioned earlier, all the different components, solid, cystic, etc., interface, and the surrounding tissue, parathyroid. How many bits? This is a bit controversial because in oncology centers, there is a thorough sampling, whereas in the others, it is more of a judgment. We have got the specimen with us, and then we can always revisit for further bits. So judgment matters. This is our MEN syndrome. The various things are mentioned. In one, I find that there can be a parathyroid hyperplasia. In 2A, again, there can be a parathyroid hyperplasia as well as a medullary carcinoma. 2B, there can be again a medullary carcinoma of the thyroid. Therefore, a thorough sampling will be required if a MEN is suspected. Also, the C-cell hyperplasia can be looked for. Parathyroid is also there in a case of MEN 4. So all these are essential and it should be covered. That is why minimum of 20 bits have been recommended. This is a checklist that you people will have to follow. And what are the modes of infiltration, etc. Not a definite CAP protocol, but almost. And these are my references. Rosai, wonderful work they have done. Japanese Society. And the Gauss Pathology, Chicago. The pathology outlines that I had been mentioning. And due credit to Grossing Surgical Oncology by Tata Memorial Center Pathology. The wise man doesn't give the right answers. He poses the right questions. Thank you for your patience.